Good afternoon, everybody. My name is Fabio Paglialonga. I'm a pediatric nephrologist in Milan, Italy, and I'm pleased to welcome you to the third joint e-seminar of the European Renal Association Young Nephrologist Platform and the ESPN Young Pediatric Nephrology Network. The topic today will be IgA nephropathy, which is a very important issue across every age group. So we have invited an adult nephrologist, a pediatric nephrologist, and a patient's representative to share with us their views, their experience, and the perspectives about this disease. But first of all, let me introduce my colleague from the Young Nephrologist Platform, Safak Mirioglu from Turkey, who will present our panelists. Thank you and enjoy the webinar.
Thank you, Fabio. Good afternoon, everyone. It's an honor and privilege to introduce our moderators for this webinar and seminar on IgA nephropathy with an emphasis on the childhood to adulthood, including the transition. Dr. Orsolya Cseprekál, she's an adult nephrologist and transplant nephrologist at the Semmelweis University in Budapest, Hungary, and currently the chair of the Young Nephrologist Platform of the ERA. The co-organizer of this joint webinar from the ERA part. And Dr. Rute Baeta Baptista, she is also a consultant nephrologist in pediatric nephrology and a PhD candidate in Nova Medical School in Lisbon, Portugal. She is also currently the chair of the Young Pediatric Nephrology Network of the ESPN and the co-organizer of this joint webinar on the ESPN side. Orsolya and Rute.
Thank you. So good afternoon, everyone. Thank you for the warm introduction. Today's webinar stands out as it addresses critical and timely questions regarding the transition of care from pediatric to adult settings, particularly from the patient's perspective. So we have seen an increase in discussions surrounding scientific and clinical inquiries at VORI's seminars. And we aim to make this session both informative and interactive. So to enhance engagement, we will incorporate poll questions throughout the webinar. So each question will be followed by a display of the results, and we will explore viewpoints from both adult and pediatric perspectives, and as well as from the patient's standpoint. So we encourage you to respond to these polling questions based on your expertise and knowledge. So following the 4 polling questions, we will have the dedicated time for panel discussions. So please feel free to submit any questions you may have using the Q&A boxes. So I would like to extend my gratitude to our speakers for accepting our invitation. As I present their brief biographies, I invite the audience to introduce themselves by indicating whether they are adult or pediatric nephrologists, patients, or affiliated with other fields. So while we are awaiting the results, so let's just start the answering. While we are waiting for the results, I'll begin by introducing our first speaker, Dr. Josh Storrar, who has undertaken his specialist training in the northwest of England and is currently based at Salford Royal Hospital. He completed a PhD earlier this year investigating the epidemiology of glomerulonephritis and rare renal diseases in which IgA nephropathy was a key topic of interest. He is representing the adult nephrology today. Our second speaker will be Dr. Alexandra Cambier. Alexandra is a specialist and pediatric nephrologist working at CHU Saint-Justine, Montreal in Canada. Her research focuses on childhood IgA nephropathy, and her research interests encompass the clinical specificities of childhood IgA nephropathy, as well as the interest of immune biomarkers for diagnosis and prognosis of the disease. And thirdly, we are also pleased to welcome Alister Humphreys, who will represent the patient's perspective today. Alister was formally diagnosed with a rare disease of IgA nephropathy in October 2020. Having had a number of missed opportunities for an earlier diagnosis and therefore earlier access to treatment, Alister is a strong patient advocate for raising awareness of the disease and for encouraging patients to participate in clinical trials to help finding a cure. Rather than view his diagnosis as potentially life-limiting, Alister has used the time since the diagnosis to achieve some of his long-held lifetime ambitions. So thank you. And if you just finished the polling questions, we will see our audience. Yeah, so half of our audience made up like pediatric nephrologists, 36 adult nephrologists, and unfortunately, thus far, we have no patients representing the. We have no patients among the audience, but it can change later on. So thank you very much. And Hiren, I just pass the word to Rute to start with the first polling question.
Thanks, Orsi. I'd like to warmly welcome all of you to this joint ERA-ESPN seminar. Thank you so much for joining, and a very special thanks to our speakers today on behalf of YPNN and ESPN. So without further ado, let's get started with the first question, which will be here. So question 1 is about a patient with presumed IgA nephropathy presenting with 1.5 grams of proteinuria per day, but no signs of rapidly progressing disease. Which management strategy would you not choose initially? Option A, a 6-month therapy course of oral steroids without a kidney biopsy. Option B, maximally tolerated doses of ACE inhibitors or angiotensin receptor blockers. Option C, lifestyle modification. Option D, management of blood pressure. Option E, addressing cardiovascular risk. So most of you would not choose initially to treat with steroids for 6 months before having a kidney biopsy. Now let's hear what our speakers think, and let's start with Alexandra. Alexandra, please, the floor is yours.
Hello everyone, I'm very happy to be here and to give my point of view as a pediatric nephrology on the question. So I think the majority of people was right. So first I'm going to introduce what is my perspective, but you know, also we have KDIGO 2021, and recently there is a draft who has been released with new guidelines about how we should treat our patients. And this draft release is from the IPNA guidelines, the International Pediatric Nephrology Association, who have done new guidelines and this guideline is going to be published in Pediatrics Nephrology very, very soon. It has been submitted and accepted. So just as an introduction, because I am the first who is going to speak, IgA nephropathy, it's a glomerulonephritis and it's a terrible one, but it's diagnosed only by kidney biopsy and is diagnosed by the presence of IgA deposits on the kidney biopsy. And as you know, there is a wide spectrum of presentation from isolated microscopic hematuria to end-stage renal disease with lots of proteinuria and gross hematuria. Children IgA nephropathy and childhood IgA nephropathy both are autoimmune disease, and even for the kids, 20 to 30% will reach end-stage renal disease after 20 years of follow-up. It's an autoimmune disease with a multi-hit development. It's important to understand that because the only way we can find a treatment is to understand what is the physiopathology of this disease. So first, in IgA nephropathy, in number 1, you have a defect of IgA1. The IgA1 has a defect of galactose. They have hypogalactosylated. It means they miss galactose, the sugar on the IgA1. The second is the presence of an autoantibody, the IgG, who is going to recognize this defect of IgA1 and form an immune complex, the IgA, Gd-IgA1. The third is the presence of the CD89, the myeloid receptor is going to be trapped in these immune complexes, and it's really important, especially in childhood IgA nephropathy. And all together, they're going to make big circulated immune complexes. And this immune complex is going to go directly in the kidney, maybe to link to a receptor with the TFR1. And due to this link, you will have a lot of inflammation with the complement activation. Pro-inflammatory mediator cytokines is going to be released, and you will have cellular proliferation with kidney inflammation. So when you understand that, it's really important to know how we should treat our patients. First, something very important treating a patient is to do a kidney biopsy. Really, a kidney biopsy is usually performed in pediatrics at presentation of symptoms. Why? First, to confirm the diagnosis, and then to assess the degree of inflammation to choose the correct treatment. So treat it by steroid without kidney biopsy is not a good way to treat a patient in pediatrics. Moreover, this patient needs to have RAPS treatments, so inhibitor of the region angiotensin blockers, and they then should treat by them. The kidney biopsy, if you read the category, say we don't should wait too much time. Like when you have a PCR between 20 and 50 milligram per millimole of proteinuria, that is not a lot, in fact. In 3 measurements on 1 or 2 weeks, we should perform a kidney biopsy. Why proteinuria is not perfect and why we need a kidney biopsy? Because in this study we have done in 2023, in 28 childhood IgA nephropathy, it was a retrospective study from 47 centers in Paris, and also one in Montreal here in Canada. We found like for in children IgA nephropathy with very few proteinuria or even less because it was below 0.03 gram per millimole, so it's very, very, very few. We found association with active Oxford score. Like we can say we found like M1, E1, and C1 in this kidney biopsy. So maybe proteinuria is not perfect, and we should not treat our patients only on the cutoff for proteinuria, but we need a kidney biopsy, and maybe we should perform it with a few amount of proteinuria. So for sure, we need to treat our patient with RAS treatments. When you have a proteinuria above 20 milligram per millimole of proteinuria, all children which should receive RAS treatment. They need also to have advice of moderating dietary salt intake below 3 or 5 grams per day. And of course, we need to give them optimal lifestyle and blood pressure control below 80% for age, sex, and weight. So I will let Josh to talk about the adult treatment, but there is a lot of difference between the indication between adults and pediatrics. And I just wanted to show you on the right, like a lot of clinical trial or retrospective study show how we treat intensively patients with steroid with a posology and a duration of the treatment, which is very different. So definitely there is a difference between adults and pediatrics in the timing and how we are going to give them immunosuppressive treatments. But also the kidney biopsy is really important for us because if you really read the category, they say like children with proteinuria, and also at least you have mesangial hyperstability, you should think to treat your patients with steroids. So, and it's very frequent to have mesangial hyperstability on a kidney biopsy.
Thanks, Alexandra. So it's a pleasure to be here. I'm going to start by, before we get to the question, just talking a little bit about IgA pathogenesis, but Alexandra has already covered this essentially, so I won't spend too long on it, but more just to say that it's an exciting time in the world of IgA nephropathy for adults, because in the last couple of years we've had two new drugs that have been approved, which I'll talk about more later on in the presentation. But and there's also lots of drugs that are in various stages of clinical trials, and all of these drugs target a different part of this pathway, which is the kind of 4-hit model that Alexandra has already talked about. And essentially, when we're thinking about treatment for IgA nephropathy, for a long time, there hasn't been a great deal of advance. And I've already mentioned that we've now got 2 new drugs available to us. And essentially, there's been a slight paradigm shift in thinking about how we treat the disease, because one of those drugs called Nefecon, or targeted release budesonide, is the only drug that is able or has been shown to actually prevent or reduce IgA immune complex formation. And so we now think that should be one of the key aims, but then the treatment should also be in parallel with that, all of the other treatment that we know. So that includes things like lifestyle modification, blood pressure control, use of RAS inhibition, et cetera, et cetera. And that's managing the consequences of existing IgA nephropathy-induced nephron loss. And so this quite nice flowchart was taken from a paper by Gleason et al. Published last year, and it takes into consideration the new drugs that are available to us. And essentially, it says that we should start by initiating lifestyle interventions, modifying cardiovascular risk, and controlling blood pressure, ideally to less than 120 to 130/80. And then if proteinuria persists of more than 0.5 gram per day, then to think about adding in an SGLT2 inhibitor if their AGFR is more than 20. And to do that for 3 months. And then if there's still persistent proteinuria, then to ideally enroll them into a clinical trial. Or if that's not possible and they have an EGFR of more than 30 mils per minute, then to think about additional treatment. And for most patients, that will be either the dual endothelin angiotensin receptor antagonist sparsentan, or Nefecon, or systemic steroids. And then in a small subgroup of patients of either Chinese or Japanese ethnicity, that there is evidence for other treatment, but only in those subgroups. Okay, so I'll let Alister speak now.
Yeah, thank you, Josh, and thank you to the rest of the panel for inviting me to speak from a patient's point of view today. I think just in terms of this particular question, one of the points that I'm keen to emphasize is the concept of early diagnosis of IgA nephropathy. I should say I'm quite old now. I'm 52 years of age, and Josh has just mentioned that in the last few years, there's been a lot of exciting developments with regard to how the disease can be treated. But in my own case, about 30 years ago, I just left university and I was about to go into my first career job. To do that, I had to have a kind of a standard medical. And I'm pleased to say I passed the medical, but in that medical, what they said to me was that I had small amounts, microscopic blood in my urine, but quote unquote, it's nothing to worry about. So of course, in my kind of early 20s, I did ignore that. But about 10 years later, when I was going for my second career job, exactly the same thing happened again, which was the same process, had to go for a medical examination. Everything was good, but oh, by the way, Mr. Humphreys, just to let you know, you have microscopic hematuria, but don't worry about it. So again, I didn't worry about it, but I do remember both of those instances very clearly. If I then roll on about 5 years from that point, I came home from work one afternoon, and all I knew was I felt very unwell. It wasn't really like me. My girlfriend, my wife at the time, said, you know, you just look awful. You say you feel awful. So she called our local GP. Local GP came out and took my blood pressure, which was extremely high. So high, in fact, that he said, we need to get you into hospital and do some further tests. One of those tests obviously uncovered the fact that I then had high levels of protein in my blood. So with a combination of blood in my urine, protein in my urine, a very high blood pressure, I had an initial referral to a nephrologist. And as I say, given this was a very long time ago, I appreciate things have changed. But all I was given in terms of treatment at that time was, again, some of the points that have been mentioned in the question. So lifestyle change, and make sure I didn't take excessive salt in my diet. And initially, I was put on to an ACE inhibitor and a calcium channel blocker. And that basically was the way that my treatment stayed for the following 10, 15 years. It was only with my annual checkup with my GP that I was able to see in some of my results that my EGFR was dropping, and it looked like my protein in my urine was going up. And I said to him, these don't look like they're going in the right direction. He said, you've got kidney disease. There's nothing that can be done about it. It is what it is. You'll go on dialysis, and you may even need to have a kidney transplant. So it was at that point, which is approximately 4 years ago, I then did some of my own research again and found that close to where I live, there is a hospital that's doing a lot of research into some of the treatments, again, that Josh mentioned. And I asked if I could go and see them. So the shorter version of that story is I managed to convince my GP to go to see this nephrologist close to where I live. Immediately he said, you need to have a kidney biopsy, where previously, albeit decades before, I was told there's no point in having a kidney biopsy because the risk of that versus you actually having what was then suspected to be Berger's disease doesn't add up. But I'm pleased to say 4 years ago, I got the biopsy. Within 2 weeks, I was diagnosed, and 2 weeks from that, I was enrolled onto a clinical trial. So my point is, if I'd, I guess, taken control of it a little bit better myself, would be the first thing to say, but also didn't just ignore the microscopic blood in my urine in the decades before, I might have been in a place where I was able to access trials and or treatment a little bit earlier.
Thank you very much. So let's just move on to the second polling question, which sounds like it's a simple choice question. So what factor do you consider the most important when evaluating immunosuppressive treatment options? So A, age of patient, B, degree of proteinuria, C, EGFR slope, D, patient preference, E, diabetes status, F, histological score, and G, all the above. Please vote. So most of you, like 76%, voted to all the above. So we are looking forward to the potential right answer. So please.
Okay, I think it's very interesting questions, definitely. I would be interested who has voted only for histologic assessments, maybe pediatric nephrology, I don't know. So yeah, it's really interesting questions, and we should take some time to talk about it. So again, from a pediatric point of view, we need histologic, we need the proteinuria, and we need the EGFR slopes, because if you look at the new update for IPNN guidelines, and also if you talk with other pediatric nephrology, always the Oxford classifications, it's a major point to decide if a patient should have systemic oral glucocorticoid or not. So if you read the new IPNN guidelines, systemic oral glucocorticoid should be used when you have at least one of the following Oxford classification. So IM1, E1, IS1, or C1. And then also, even you don't have the proteinuria, you could think to treat them with systemic oral glucocorticoid. Of course, if you don't have any kidney biopsy, but you're just following your patients and you have an important proteinuria or a relapse, you could choose to switch your RAS treatment blockade or to take in additions your RAS treatment blockade with the systemic oral glucocorticoids. eGFR is also so the eGFR slope is very important also because for sure it will help you to know if your patients need methylprednisolone, and in the new guidelines they say we need intravenous methylprednisolone. So if your eGFR slope and eGFR score is below 80 ml per minute, the pediatrics should receive intravenous methylprednisolone. Also, you should think to give intravenous methylprednisolone if you have a proteinuria above 100 milligram per millimole, and this time with the two of the following scores of Ox classification, so M1, E1, S1 of the podocyte lesion or C1. Also, if you have a children with the cholestatic forms with C2, so a lot of proliferation, extra proliferation, it's an indication also to give them intravenous methylprednisolone, regardless the proteinuria. So why we treating intensely your patients? If Josh is going to talk, and I'm sure he's not going to give you the same perspective, but why in pediatrics we want to treat so intensely your patients, and why we put so much intensity of the Oxford classification? Because when we discover our children, most of the time, it's very early in the life, and they have all the life in front of them. And when you hear the Alister story, we can understand we want to do quickly a kidney biopsy to know what is it inside, and we want to give them the best treatments. And if you look this study we have done in 2020, what is interesting, it's the proteinuria is not the same between adults and children, and there is clinical and histological differences between adults and children in new onset IgA nephropathy. To resume this study, in pediatrics, the proteinuria of our children is associated with glomerular proliferation, and this glomerular proliferation is going to be to response to corticosteroid, whereas in adults, proteinuria is more associated with chronic lesions. And also, if you compare both cohorts, what you could see is our patients in pediatrics has less T1 atrophy lesion than adults. So that could explain when you have more proliferation lesions and less chronic lesions, that could explain why our children have a higher corticosteroid sensitivity, whereas in adults, you have a lot of trials who show maybe steroid is not efficiency in adult IgA nephropathy, last trial who was Stop IgA. And if you look in this study, you can see like the proteinuria in children is decreased more importantly with steroid compared to adults, and the eGFR slope was the same. So the response is higher in pediatrics treated by steroid than in adults.
Thanks, Alexandra. So I guess when thinking about this question, we are thinking about what treatments will deliver the greatest benefit with the least amount of harm. And we know that if we use immunosuppression, they come with significant side effects. And I guess we also know that IgA nephropathy in adulthood can be quite a heterogeneous condition. So some patients will stay at a similar level of kidney function for many years, with likely to have low levels of proteinuria and are unlikely to benefit from immunosuppression, whereas other patients will progress very quickly and we will want to be able to treat them more effectively. So in 2019, the International IgA Nephropathy Risk Prediction Tool was created, and the image on the left is taken from the current 2021 KDIGO guidelines. And essentially, what this study did in 2019 was to take a huge number of patients with IgA nephropathy internationally, several thousand. So it was a multi-ethnic, multinational cohort, and derived an equation to try and work out what clinical and histological features were more likely to indicate or were likely to indicate that someone was at higher risk of progression. And these are all the features that they identified. So it includes their eGFR at biopsy, their blood pressure, proteinuria, age, race, whether they were on an ACE or an ARB, and their histological score, and whether they were taking immunosuppression at or prior to biopsy. And you can, this was then subsequently validated on a significant number of patients as well. And there was a high degree of correlation between what was predicted and what was observed. So this can be used clinically. It's the first time that we had something that we could use to try and identify those patients who are at high risk of progression. And the image on the right is taken from the online calculator, which anyone can use. And you plug the numbers in, and then you get a percentage, and that percentage is someone's risk of developing end-stage kidney disease or 50% reduction in their eGFR up to 7 years post, up to 7 years basically from doing the calculation. And it's only validated for at the time of biopsy. So you can't do this down the line, sort of several years down the line. You have to do it at the time of biopsy. And then I just want to spend a few minutes just talking about the NefIgArd trial, because this has basically led to a new treatment for IgA nephropathy. So this was a randomized control trial comparing Nefecon, which is, as I've already mentioned, targeted release formulation of budesonide, which specifically targets the small intestine, which is where there's supposed to be this excess production of aberrant IgA. And so the eligibility criteria, patients were over 18 with an eGFR of between 35 and 90 mils per minute. So it excluded patients with very advanced disease. And they have to have proteinuria of more than 1 gram per 24 hours, despite being on optimized RAS blockade. And they either got placebo or they got Nefecon. And if they got Nefecon, they got treated for 9 months at a dose of 16 milligrams per day. And the primary endpoint of the trial was time-weighted average eGFR over a 2-year period. That's the study there. And the results, so there were 182 patients in each treatment group. Majority were men and 76% white. And the trial, the main outcomes looking at proteinuria and time average GFR showed that there was a 27% reduction in proteinuria at 9 months in the group who were given Nefecon compared to placebo. And there was also a significant but less severe drop in eGFR in those who were given Nefecon. So the eGFR was minus 2.47 mils per minute in the group who were given Nefecon, but minus 7.52 mils per minute in the group who received placebo. So about a 5 mil per minute difference over that 2-year period. And then just looking at the safety profile, the most commonly reported adverse events are as listed. And interestingly, there was no increased risk of infection in the group who were given Nefecon. And that's quite important because most of the other previous trials in IgA nephropathy that have looked at steroids all showed a significant increased risk of infection in those who were given steroids. There were more adverse events in the Nefecon group, and 4 patients who were pre-diabetic in the Nefecon group progressed to diabetes over the 9 months period. What is not clear from this study is what was investigated in the trial was a 9-month course. So it's not clear whether repeated courses may be needed over time, or if there is an optimal kind of maintenance dose that would be recommended.
Thank you, Josh. I think just two relatively brief points I'm keen to make on this question. The first one is I'm pleased to see that no one selected age as criteria. So obviously the fact that I'm quite old these days isn't relevant from the perspective of IgA nephropathy. But the second point is just to raise from a patient's perspective the importance of the risk prediction tool that Josh just mentioned. So again, when I was formally diagnosed, and I describe it as formally diagnosed because until that point, I guess as far as I'm concerned, it was only suspected. But at that formal diagnosis, I was told about the risk prediction tool, and it is something that I track myself against. And whilst I'm on a clinical trial, as I mentioned previously, I'm pleased to see that I'm currently tracking slightly ahead of that prediction. So it is something that gives a degree of reassurance to patients that this is something, A, that's based on science, and B, is an indicator, because the sense you have when you get that formal diagnosis is effectively a ticking time bomb. And at what point am I going to need dialysis? At what point am I going to need kidney replacement? So just to emphasize the importance of that particular tool from a patient's perspective.
Now let's move to the third question, which is, which of the following patients would you consider treating the most intensively? Please try to read the question as I do it, because then you can vote right after it. So option A, a 17-year-old female with minimal proteinuria, EGFR higher than 90, and a MSC score of M1, E0, S1, T0, C0, plus international IgA nephropathy risk prediction of 50% decline in EGFR or progression to end-stage chronic kidney disease 5 years after the biopsy of 2.91%. Option B, a 28-year-old male with urinary protein to creatinine ratio 130 milligrams per millimole. This corresponds to 1,150 milligrams per gram or 1.2 milligrams per milligram. EGFR 74 and a MSC score of M1, E1, S0, T1, C0, plus the prediction tool of the risk after 5 years after the biopsy of 4.11%. Option C, a 45-year-old male with urinary protein to creatinine ratio 75 milligrams per millimole, which corresponds to 663 milligrams per gram or 0.66 milligrams per milligram. EGFR of 32 and the MSC score M1, E1, S0, T1, C1, plus a score with the prediction tool at 5 years after the biopsy of 12.06%. And finally, option D, a 65-year-old female with a urinary protein to creatinine ratio 180 milligrams per millimole, which corresponds to 1,592 milligrams per gram or 1.5 milligrams per milligram, an EGFR of 24, and the MSC score M0, E0, S1, T2, C0, plus the prediction risk score at 5 years after the biopsy of 16.91%. So most of you picked option C. Let's see what our speakers think about this. Now back to Josh. Please go ahead.
Thank you. So yeah, that was quite a difficult question, I think, and it was kind of getting you to think about who's at most risk of progressing, and then also thinking about who would be most suitable to have some of the more intensive treatments. I've got a couple of slides on the most recent KDIGA guidelines, but before I get onto those, I just want to quickly mention the PROTECT trial, which was published last year, which was a randomized active control trial comparing the dual endothelin and angiotensin receptor antagonist sparsentan with irbesartan, which was considered kind of current standard of care. And it enrolled patients who were over 18 on maximum RAS inhibition for at least 12 weeks, with proteinuria of at least 1 gram per day. And their eGFR had to be greater than or equal to 30. So again, it excluded those patients with very advanced disease. There were about 200 patients in each group, 70% male, 67% white. And it showed that there was a slower rate of eGFR decline in the sparsentan group versus the irbesartan group. So a difference of about 1 ml per minute. And there was also a significant reduction in proteinuria in the sparsentan group. So they had their baseline proteinuria, the change from that was 40% lower in the group who received sparsentan. And there was a similar adverse event profile between the two groups. So this trial kind of demonstrated the efficacy of sparsentan for use in patients with IgA nephropathy over and above using irbesartan. So this is taken from the 2024 clinical practice guidelines for IgA nephropathy, which is currently in draft form and it's out for public review. So I imagine it will get published formally in due course. But these are the 5 recommendations that they make for managing IgA nephropathy. So they say they suggest treatment with a 9-month course of Nefecon for patients who are at risk of progressive kidney function loss. They say when Nefecon is not available, then it should be you should consider treatment with a limited course of reduced dose steroids combined with antimicrobial prophylaxis after a thorough toxicity risk assessment. And the reason that they're being quite careful there is because of the significant increased risk of infections that all previous trials have shown when looking at using oral corticosteroids. They also say that all patients who are at risk of progressive kidney function loss should be treated with maximally tolerated ACE or ALB, which is fairly standard. And they also suggest that patients should be treated who are at risk of kidney function loss should be treated with an SGLT2 inhibitor. And they also suggest that patients should be treated with sparsentan. And you can see the level of evidence there is moderate. So there's some debate over some of that. And then some of the practice points that they said are here. So how they categorize someone at being at high risk of progressive loss of kidney function is if they have more than 0.5 gram per day of proteinuria. And that's whether they are on or off treatment. And so if they do have more than 0.5 gram a day proteinuria, then they should be on some form of treatment or their treatment should be escalated, is what you could infer from that. And the treatment goal should be to ideally aiming for a rate of kidney function loss of less than eGFR of less than 1 ml per minute per year for the rest of their life, and to maintain proteinuria at less than 0.5 gram per day, and preferably less than 0.3 grams a day, which I think is quite a tall ask. And then, as I previously mentioned, the focus of management should be on reducing the immune complex formation and immune complex mediated glomerular injury, alongside managing existing IgA nephropathy induced nephron loss. And then the management should include all of the things that we've already talked about, including blood pressure control and lifestyle factors, RAS blockade, etc. So, yep, and then I think there's 3 more. So when considering Nefecon, it's reasonable to use a 9-month treatment course for patients who are at high risk. But it's unclear, as I've already said, whether repeated courses or a maintenance dose may be needed. And the availability and approval status of Nefecon might vary from country to country. there are multiple other treatments that have been investigated for use in IgA nephropathy, but none have shown a consistent benefit. There's also a question about whether it would be possible to use both systemic steroids along with targeted release budesonide, and I think the jury is still out as to whether that is an option, and if it is, what dose of steroids to give. And I think that's a debate that we could have on another day. But I think, yeah, and then I've just got a slide just to mention that there are several clinical trials currently in development looking at novel drugs, particularly looking at BAFF and APRIL inhibitors. So BAFF and APRIL is important for B-cell class switching, which is thought to be responsible for the abnormal IgA production. So there's a few examples there. And then we know that the complement system plays a significant part in causing glomerular injury. And so there are various drugs looking at complement inhibitors. And I think just before we move on to Alister, just going back to the original question, I think I probably would have chosen C, just because, well, both patients C and D have the highest risk of progression as per the International IgA tool, but patient C has is slightly younger, so potentially has more to benefit, but also has a higher EGFR. So if you were thinking about giving glucocorticoids, you probably would avoid those in an older patient who had a lower EGFR. But I think both of these patients are at risk of progression. So in reality, you'd be wanting to have a chat with them and see what they were keen for, and then have a discussion with them about the different options.
I think just briefly, 2 points, again, following this question. The first one is it's pleasing, I think, to see that the target that the guidelines are quoting is to have proteinuria certainly under 0.5 grams a day, if not 0.3. And again, just I think it's an indication of how much research and development has gone into the disease in the last few years. Because 4 years ago, my target, if you like, for proteinuria was 1 gram. So here we are 4 years later, and that's half again. And from what I understand of the disease, that's probably the best indicator of progression to end-stage kidney failure. So it's good to see that that's something that, from a patient's point of view, there's if you like, a target to aim for, given the medication and the other lifestyle changes that a patient can take. And again, just the second thing, not only did Josh take us through a number of different studies that have already been published, but he talked about at least 2 or 3, I think, on the last slide, that are still ongoing. So it's great to see that there's lots more coming through in terms of pipeline drugs.
Thank you very much for the comprehensive responses for the third polling question. So let's just move on. Let's just move on to our last polling question. So please prepare yourself for voting. It's, again, a simple choice question. So which of the following statements concerning drug treatment in pediatric IgA nephropathy is true? So kidney biopsy results should be used for diagnosis, but not to decide the treatment. B, there is strong evidence to support the use of RAS inhibitors, RAS antagonists in children with IgA nephropathy. C, corticosteroids prescription should not be based on results of kidney biopsy, regardless of clinical findings. And D, every patient with urinary protein-creatinine ratio more than 0.2 needs immunosuppressive treatment. Okay, so 65% of the audience responded B. So let's see what could be the right answer. So please, Alexandra.
Yes. So it's always a good question, and you are going to think I am obsessed with kidney biopsy. So first, of course, there is a strong evidence to use RAS blockade treatment in children. I mean, all IgA nephropathy in childhood IgA nephropathy should receive RAS blockade treatment when you have a proteinuria above 20 milligram per millimole, but it's very few amount of proteinuria. So majoritarily, all the patients should be treated by RAS blockade treatments. And there is a lot of randomized clinical trial who show the interest of treating the patient with the RAS blockade treatments, because also there is an effect of the inflammations on the kidney in vitro, but also in vivo. So yes, definitely we need kidney biopsy, not only for the diagnosis, of course we need it for diagnosis, but also it's really important for treatment decision, as I show you with all the KDIGO guidelines, all the IPNA guidelines, and in my perspective point of view, we really need a kidney biopsy to choose a treatment. Choosing a treatment only on proteinuria or IgA first slope, I think, is not a good way to treat our patients. We need to follow the kidney biopsy. We need to follow the Oxford classification. So for the follow-up, for the prognosis, for the diagnosis, for the treatment decision, if there is something I think it is important today to know, it's in pediatric childhood IgA nephropathy, we need a kidney biopsy to treat our patients. Something I wanted for you to remember is these children need follow-up all the life. We need to have a proteinuria below 20 milligram per gram per day. We need a blood pressure which is controlled. We need to follow a patient after a complete remission, even they don't have any proteinuria anymore. They can relapse even after many years, so they need to be follow-up. And they need yearly monitoring of blood pressure and urine analysis for patients with a history of pediatric IgA nephropathy. To finish on something very optimistic, I know we're running out of time, but there is new advances in treatments for IgA. Unfortunately, there is no open clinical trial in pediatrics. But there is we're going to have good hopes that maybe we can someday offer more than just steroid treatments. So as you can see, now we have a lot of way to block our physiopathology. Like I know Josh talked about a few slides before, maybe we can block BAF and APRIL for a patient, and I don't have time to present data, but we have interesting data about APRIL in childhood IgA nephropathy and could be really an interesting option. We can block the proteasome with bortezomib. We could block also the toll-like receptor with hydroxychloroquine that we use already in lupus nephritis. Of course, there is a multiple way to block complement pathway. We can also use, unfortunately, there is no clinical trial in pediatrics. And of course, we have now the Nefecont for adults, but as you know, and if we have time, I could answer maybe some question about it. We can also use budesonide maybe for some patients, especially for adolescents in childhood IgA nephropathy. So this is the same. We can see we have a lot of molecules today to block the PAO patch with budesonide, to block the macrophage, the toll-like receptor with the hydroxychloroquine. We can block APRIL, we can block BAF, we can block the proteasome with the betazoid. So we have a lot of clinical trial we should also perform in pediatrics. And this is the same for the complement pathway. You can see there is wonderful molecules we could try, the iptacopan for the factor B, the vemiricoptan for the factor B. We can block the lectin pathway with the MAPS2 inhibitors, or we could go to the ravulizumab or cemsidomide, the C5 inhibitors. So we definitely need to propose other treatments than steroids now for our children. because even they have less side effects than in adults. I mean, infections are less common than we can see in adult patients. For sure, steroid is going to have impact of the bones and the growth of our kids.
I think just to mention briefly, and Alexandra did at the beginning of that response, just the importance of the kidney biopsy. Having had one 4 years ago, it's not particularly pleasant, but as a result of the biopsy, I had a very clear diagnosis of IgA nephropathy, which is something I didn't have for decades. And just that certainty of diagnosis made such a big difference to me. And if I'd had biopsy 10, 15 years earlier, then I would have had that certainty much sooner. So just emphasize the importance of that biopsy.
Thank you all very much. I think now it's time to move to the final discussion. I may read the questions that are still to be answered in the Q&A box. So one of the questions is about managing a patient with IgA nephropathy who is between the ages of 16 and 18 with microhematuria and proteinuria between 200 to 500 milligrams per day, because this patient will be considered to be in remission if he was an adult and to have significant proteinuria as per the pediatric guidelines. So the question is, how would you treat this patient?
You want to answer first, Josh, or you want to answer first?
You go first.
Okay. So from a pediatrics point of view, definitely is not a remission. And I would perform a kidney biopsy to see what is it? Is it maybe there is nothing to treat? Maybe there is endocapillary proliferation. So it will depend what type of proliferation I could have. If there is not so much important proliferation, I mean, let's say 50% of mesangial proliferation or few endocapillary proliferation. I think this is, and the patient is an adolescent and she's afraid to have steroid and to have a lot of side effects. This is an option where I could try the budesonide. I could give her directly budesonide, or I could give her like 1 month of steroid, and if she has a good response, I could tapering with giving budesonide. Is something now I'm doing here with my colleague, and we have some patients who have done that and we have good results. So we should publish it soon, I think. But this is my point of view. I would definitely do a kidney biopsy before shooting any treatments.
Thank you very much. And Josh, what would you do?
Yeah, I agree. I don't have a huge amount of experience in managing patients of this age, but I think if they have minimal proteinuria, then I'd be more tempted to kind of watch and wait. I think you'd want to know what their trajectory of their kidney function has been up to this point. And then, yeah, definitely have a kidney biopsy and then have a discussion with them. But if their kidney function is stable, I'd be inclined to kind of watch and wait for the time being.
Makes sense.
The only step, Josh, is most of the patients, they have eGFR normal slope. It's very rare in children with idiopathy you have like a decreased eGFR slope because they don't have any chronic disease. So that's why sometimes we don't wait. Like if you see a paper, most of the time we wait less than 3 months before performing a kidney biopsy for a new diagnosis due to the absence of the renal kidney dysfunction. Because they have only proteinuria. So this is the only way we can monitor patients is monitoring the proteinuria or doing a kidney biopsy.
Yeah.
Thank you very much. So unfortunately, we have already run out of our dedicated time. So even if there were a lot of more questions to discuss regarding treatment, for example, in rituximab or mycophenolate, or what to do with a kidney transplant patient with a relapsing IgA nephropathy, etc. So we should have dedicated a little bit more time to this webinar. But anyway, thank you very much for your comprehensive overviews and responses to the questions, and which elaborated the most crucial points of the diagnostic and the treatment. And also, thank you very much, Alister, for your reflections. And these reflections to the different clinical questions were of huge importance and mirrored closely the paradigm shift that called the attention to what extent a guideline could work in the real life or not. So we have a lot to do with IgA nephropathy in the future. And so thank you very much for accepting our invitation and for our audience to be here. So thank you very much.
Thank you, Orsi. Now our joint webinar with the ESPN, the YPNN, has come to an end. On behalf of DRA YMP, I want to thank all the speakers, panelists, and participants for this excellent work, and want to give the word to my co-moderator, Fabio.
Thank you, Safak. And I'd like just to thank again our great speakers for this amazing webinar, and thank every one of you for attending today. Please don't forget to give us your feedback through the questionnaire, and please suggest us some possible topics for the next joint webinars. Last but not least, I'd like to invite all of you to our next ESPN annual meeting, which will be held in Valencia at the end of September. Thank you so much again to any one of you, and have a nice weekend.